tried to go on, and Yemen as well, he knew that we are having the meeting now. He's supposed to go on.
Okay, so both of them not on yet. Only Anud is on. Should we start or should we wait one?
Start.
Okay. So, hello everybody. My name is Yahya Ithaw. I'm a consultant neonatologist, and I'm also director of. You don't need. Okay, you mute yourself, please. So I'm the director of the Neonatal-Perinatal Fellowship, and my friend and my colleague, Dr. Arula, is the assistants of the program. And these are, half academic days. We're gonna kick off with this one, but also we will have speakers from around the world, from Canada, Australia, UK, KSA, here from UAE and others for different topics in neonatology. And today will be, I kindly ask everybody to mute himself, apart from Rula, Anud, Mona, and Yaman, because we're gonna have a sort of interactive discussion. So the objectives of this talk, today we will be talking about apnea. You please mute yourself. Rula, you are your co-host and your manager, so you can mute everybody. You can control. You can take off. I can see Anud is not activating her mic, so probably she cannot hear me. And I didn't see Mona and Yamin joining us. So the objectives of this talk is to talk about the background of apneas, the pathogenesis, how we will monitor and how we evaluate, and then how we do a discharge considerations. There is a little bit of some other topics in between, and we will see. So to know, for those who are expert in neonatology, this topic is also only the basics to start the foundation of the topics. We will not go to the details, but it's a kind of for those novice with apnea of prematurity. But I will be happy to take questions at the end, and at the end of the session, we'll have some private discussion with our fellows. So let's start with the definition, background, the definition, classification, and incidence. So apnea simply means cessation of airflow. When we say apnea, we are pausing the respirations. And when we say pausing, it's within a specific period of time. But the apnea can be physiological and can be pathological, or that pausing or that cessation of airflow can be pathological and can be physiological. So when it's pathological, it's called apneic spell. When the airflow cessations or absence of airflow or pausing of airflow is prolonged, and the accepted time of considering prolonged is 20 seconds. Now, why 20 seconds? No evidence. It's just by tradition. It seemed like a good number. Should you consider this less than that time? Yes, sometime. Should you consider prolonged? Then can you please mute yourself? Who is not muting himself? Let me check. Okay. So can we go longer than that time sometime? Yes, the question is yes. However, sometime when it's associated with other signs, we can go longer. What are these other signs? Bradycardia. What is bradycardia? I'm going to take off anybody. Ayman, Abdul Mufti, please mute yourself, okay? Mute yourself, please. I muted you 3 times now. When it's accompanied by bradycardia, and how we know it's a bradycardia? What is the definition of bradycardia? We don't know, but we always use the number 100 beats per minute. When it's less than that, it's called bradycardia. Now, how long it should go below 100 to be considered bradycardia? It's probably, Mona, mute yourself, please. So how long it goes below 100 to be considered brady, we don't know, but I usually, in my practice, I use 5 seconds. And also, there should be hypoxia. Now, there is a difference between hypoxia and desaturation. Now, by tradition, when the oxygen saturation goes below, but above 85, I would say this is a desaturation. When it goes below 85, I would consider it hypoxia. Now, why is that? Because hypoxia means there should be something called clinical cyanosis. And when cyanosis will occur, usually cyanosis when you have 5 grams of hydroxyhemoglobin. So let's say your hemoglobin is 16, and 5 grams mean 5 out of 16, around 37%. That means your desaturation will not occur until you are 63. But for neonate, for safe side, we consider desaturation up to or down to 85. Anything below 85, we consider it hypoxia. And of course, hypoxia and desaturation both are assessed and seen when we look to the pulse oximetry. Now, there are other ways of diagnosing hypoxia by looking at local oxygenation, or we use what's something called NIRS, near-infrared spectroscopy, but this is very expensive and usually is not available for routine use. So most of the definitions in the textbooks and in the articles, we use the pulse oximetry, or what we call it, the systemic oxygenation, not the local tissue oxygenation checked or measured by NIRS. Now, the bradycardia and desaturation usually appear after 20 seconds. Hence, we select the 20-second timetable for definition of apnea. Okay. However, sometimes, and especially with lower gestational age, these can occur before 20 seconds pass from cessation of breathing. And that's why the definition includes either 20 seconds or less than 20 seconds with these two features. If desaturation continue, then there's other manifestations like how the patient respond to cessations. Like if you are an adult and you get hypoxia, for example, you go above sea level, you climb a mountain and you go high, and then you get hypoxia, your response usually is rapid breathing and periodic breathing. However, the baby response is a little bit different because of immaturity of respiratory drive. So if hypoxia continue and apnea continue, then you get pallor or hypotonia. And then the infant might be unresponsive to tactile stimulation. So it's vital when you manage apnea to do tactile stimulations. And that should happen before you go to the irreversible or secondary apnea. And usually start when you see the baby violet color pallor, and his tone become very, very, very lax. Now, the level and the duration of bradycardia and desaturation I already spoke about, and usually I take 5 seconds. And if you say why 5 seconds, because I think the cerebral blood flow, and also, again, I don't have evidence for that, cerebral blood flow and the oxygenation of the brain and other vital organs start to affect after 5 seconds of serious hypoxia. And remember, when we say hypoxia, we mean appearance of cyanosis. And when we say cyanosis, we mean amount of hydroxyhemoglobin is 5 grams. And usually most of the time it's 25%. So we're talking about 75. So down to 85, we said desaturation. Below 85, I consider it hypoxia, but you remember the hypoxia is when you get 5 grams of hydroxyhemoglobin, not the oxyhemoglobin. Now, how we classify the apnea? It is usually subjective classification. There is no very objective because it's hard to separate the types of apnea between each other. And the definition depend is because we've said apnea absence, cessations, or pause of airflow. Sometimes you have that, but still you have respiratory effort. So if you have respiratory effort, but there is no flow, then it's different from you don't have respiratory effort and you don't have flow. So that is the basis of classification. And when we say there is a flow, but there is a respiratory effort and there is no flow. So this is mostly obstructive, and most of the obstruction occur in the upper airway. And I know some of the fellows and even some of the physicians, they have hard time differentiating between upper and lower airway flow. So when we say upper airway flow or upper airway anatomy, we mean any airways above the thoracic inlet. So, and why is the thoracic inlet is the mark between upper and lower? Because, yeah, somebody's texting me. Ayman, you can ask later on. When I finish, you'll get all the answers. And then when we finish, you can ask on the end. So when we say upper and lower thoracic inlet is because the physiology change, the physiology of movement of air from outside to the upper airway, and the movement from the upper airway to the lower airway, and then the movement from lower airway to the upper airway, and the movement from the upper airway to the outside. The physiology of this movement change, and the change of the physiology is at the thoracic inlet. And therefore, we have, the question should be at the end. So therefore, we have upper airway. And when we say obstructive apnea, we're talking about obstruction of the upper airway. Now, when we say central apnea, we mean there is no respiratory effort. So you don't have flow, absence of flow, or pausing of flow, and there is no respiratory effort. And sometimes it can become mixed. So you start with obstruction, and then because the cerebral blood flow start to be affected, then you get also, in addition to the obstructive, you get central. So it can sometimes be mixed. Most of the obstruction of the upper airway is at the pharyngeal level. And because that is the smallest part of the upper airway in the newborn babies. And as we said, mixed apnea starts with obstruction, then followed by central problem. Now, what is the threshold? We've talked about it. Apnea, when it's more than 15 seconds or 20 seconds, depend on the literature and the definition. Heart rate, when it's less than 70 or 80, most people use 100. And oxygen saturation, less than 80 to 85, when it's become hypoxia, not only desaturation. Now, the periodic breathing, and it is a problem with in neonatology. Periodic breathing is, as you know, the baby's pattern of the breathing are not consistent. So you have a fast breathing, alternate with brief, slow breathing, and sometimes irregular breathing. And this is the reason for that, because of the immaturity of the respiratory drive, whether central or peripheral chemoreceptors. And it's very hard to define if you go to the literature, and I have done a study about using car seat and apnea and using NIRS. It was very hard to define what is periodic breathing. But I would say it's a pausing of respiration or irregular respiration between, pausing between regular and irregular respiration for 5 seconds. And the reason why 5 seconds, as we said, if you pause the breathing by obstruction for less than 5 seconds, you will not have secondary central apnea, because your CNS will not be affected. Your cerebral blood flow will not affect. And that's why I use the definition of 5 seconds of pausing of breathing. Now, if you say how I see that, you can see it on the monitor. You can watch it live, and you can do smart monitoring by retrogradely monitoring the pulse oximetry. So I use 5 seconds. If less than 5 seconds, I would say this is more periodic breathing rather than real desaturation. Now, when we say pause of breathing, there should be desaturation with it. Okay? And when we say also pausing of breathing, there might be bradycardia with it. Now, how will we differentiate between desaturation of apnea, bradycardia of apnea, and the bradycardia and desaturation of pausing is when they recover spontaneously. Today, I have a call from other country about a doctor who gave birth to a newborn babies, and they have sometimes saturation goes to 79. So I said, well, that's normal if it's recovered by itself, if it's less than 5 seconds, because even if you put a saturation monitor on yourself as an adult and you eat or you run or you get stress or you do something, you get some dips. That is normal, that is natural. Sometimes also because of the position of the baby, and if the baby can correct his or her position and improve, then that's also called periodic breathing, not desaturation. As far as it recovers spontaneously, as far as less than 5 seconds, then it's a periodic breathing. And remember, periodic breathing is the norm of a preterm infant. You rarely have a preterm infant regular breathing. The norm is periodic breathing, so it's very common. It's probably 95% of newborn babies. And it's not easy, it's not hard to differentiate it from real apnea. If it is still periodic breathing, but desaturation are frequent, even if it's less than 5 seconds, but we have something called cumulative desaturation. So if your cumulative desaturation around 10 minutes in 24 hours, then probably also you have a problem. Probably you need some stimulant, you need some position correction, maybe environmental, maybe the humidity, maybe the temperature, maybe you need some respiratory support, maybe the way you feed the baby. So remember also to check retrogradely in a smart way, you observe your saturation level over last 24 hours. Now, what is the incidence of very common? Very common. I don't think you need incidence. I think it's the norm of newborn babies. And it increases with decreased gestational age. And it's very frequent for babies less than 28 weeks or less than 1,800 grams. And I would say it's about 25%. It's almost always present below 28 weeks. And it's almost always about 25% of babies less than 1,800 grams or less than 24 weeks gestational age. And when we say apnea, we are talking about at least one episode of apneic spill or pathological apneic spill. Now, what's the onset? Usually after the honeymoon period of delivery of the end. And usually it is within first 2 days, but sometimes it goes up to 7 days. So the baby is fine within the first 3 days, and there's other problems start to occur. Feeding, PDA, and an infection, and other things, and maybe IVH, and all start to contribute, and the babies start to have apnea. So most of the babies get the apnea before 7 days, and most of them, they get it after 24 hours. Now, if it starts within 24 hours, then probably this is a serious problem. Probably if it's within 24 hours, I would think this apnea like when I think for term baby. So preterm babies, we said it's a physiological. It is a norm. But in term baby, it's a pathological. There should be a reason. In preterm babies, usually there is no reason other than immaturity of the respiratory drive. If it's within 24 hours, then I would start to think about it in the way I think about the term baby. Now, when the apnea will disappear, most of the time, it disappears about 33 weeks. Sometimes it goes up to term baby. Now, the younger the baby is, the longer the apnea will last. I have seen apnea continue until 42 weeks. So the older the gestational age, the younger the apnea will cease. The younger the gestational age, the older the apnea will cease. Okay, so for 24 weeks, I think it will last more than 42 weeks. For 28 weeks, it will usually stop around term age, somewhere between 37, 38, 39. For babies older than 30 weeks, usually it disappears about 33, 34 weeks. Sometime when the apnea disappears, still you have intermittent hypoxic event. And again, these are very frequent, less than 5 seconds, not associated with other features. And when you count them accumulatively over 24 hours, they are a short period of time, the baby is growing, no other features, then probably I would consider this as a norm or as a variation of norm. And I would not consider resuming the treatment if I have a little bit of intermittent hypoxia after the cesations or the resolutions of the apnea. Now, there is a study, I've referred it here to Chimi, and you can review it now. I don't want to go to details of it because that's not the purpose of this presentation, but you can Google it and you can see, and you can have the normal values. It tells you exactly some data about when and when to start and when to end the apnea. But the clinical significance of these numbers and the percentages are usually for standard of care as is uncertain. Now, for term baby, this is the different whole story. So remember, when talking about apnea, we're talking about apnea of prematurity. When we're talking about apnea of term, this is a totally different term. And I would consider term and near term the same when I have apnea. So any babies more than 36 weeks, more than 35 plus 6 completed weeks, I would consider it, this is a term. And when I say term, it's a pathological. So I have to look for a cause. And remember, there are many causes of apnea or apnea-like. Seizure might appear as apnea because it can be tonic or atonic type, or just pausing or subtle type of seizures. So birth asphyxia is vital. Hemorrhage is vital. Seizure, depression from medications. In term baby, mostly these apneas are irreversible, caused by irreversible structural abnormality. Sometime it can be by medications or some metabolic problem. Most of the time, again, we have to consider the environmental factors, especially if we have no proper transport between units and between hospitals, especially we're talking about, or you're not practicing golden hour. So, hypothermia, hypoglycemia, and hyperthermia, electrolyte disturbances, all that rarely can cause, not rarely, but can cause, but these are correctable. But most of the time, baby, most are, the apnea are due to irreversible structural abnormality such as birth asphyxia, intracranial hemorrhage, seizures, and other factors that can cause the, but sometimes it's due to environmental or metabolic problem. Now, what is the differential diagnosis of apnea of prematurity? The most common is apnea of prematurity. What can cause anemia? Now, anemia, they say it causes, surprisingly, anemia, they call it cause apnea. But when you treat anemia by blood transfusion, it is not a correction for apnea. It even might contribute. So if you look at the evidence, anemia is listed as a cause of apnea, but correction of anemia does not improve apnea. But however, you have to improve it. Infection, very common, any apnea, infection, and then something else. Infection are very common. Metabolic, especially hypoglycemia. So in your target, the baby should receive sugar. If any baby less than 30 weeks, the sugar should hit the baby by 10 minutes of age. By 10 minutes of age. and it should not be after 20 minutes of age. So if you have no ability, you try twice and you get no peripheral access and the central access gets long time, my suggestion is to use glucogel. Glucogel is being used, being recommended by Canadian Pediatric Society, and it is when it used less than 400 grams, it does not affect the osmolality and is not associated with neck. So it's very important to remember babies, when they born, they have continuous supply in utero of sugar, and when you suddenly cut off the sugar, they have no store, they got suddenly. And for me, I consider the normal level between 4 and 8. I like it in the first 72 hours to be above 2.7 millimole per liter. After 3 days, I like it to be more than 3.3. When it is less than 2.6 or 2.9 less, I would give supply. When it's become 1.7, then I consider it glucopenia. And glucopenia means when the brain starts to suffer. So it's vital to consider hypoglycemia when you're talking with apnea, even if premature babies. Again, temperature. Temperature is important, environmental temperature. And remember, temperature is also affected by humidity. So you need to make sure that your temperature is okay. And I know many people are mixing that. They think that all the incubators are same and all the incubator can be used for all the gestational ages, which is incorrect, because babies less than 27 weeks, they need special type of incubator. They should be double wall, they should be frequency approved, they should be a neutral environment, they can achieve 100% of humidity. When we say 100% of humidity, is as if you are submersing your head in the water. So make sure that when you talk about temperature, make sure that the humidity are okay. Very important to take history from maternal. You have magnesium sulfate, very common. We use it now for prophylaxis to protect as a neuroprotective. Also the opiate, use of the opiate. And then when you have opiate, you have to consider or not the naloxone, but always do not consider naloxone. And this will, the temperature, the hypoglycemia, and then it occur in the first 24 hours. And that's why I said it is between, two brackets that when we talk about apnea and then 24 hours, it should be think in a term way, as if the baby is term, and look for causes. Look for general anesthesia if mother is received, or local anesthesia. Look for, of course, local neurological problem. Again, necrotizing enterocolitis, especially if the age after 1 week, up to 21 days. The average of neck usually occur at 11 days. Look of the upper airway abnormality, especially if we are in the first 24 hours. Seizures, very important in term baby and near-term baby, but can occur in preterm babies. Feeding problem, you have to manipulate the feeding, you have to, when you consider the baby, because most of the time when we say bolus feed, or when we say gavage feed, now when we say bolus feed or gavage feed, we're talking about 20 minutes. And the problem is sometimes we are, what I call it is idiopathic, or not idiopathic, is something that we create. And then we call it apnea, which means when you give feed, we're talking about 20 minutes. When we give breastfeed, we're talking about 20 minutes. Should not be less than 20 minutes. And the feeding, when you do gavage, which is milk going by gravity, the column can be lowered down or raised up to keep the milk within 20 minutes. And the milk should not go less than 1 ml every 1 to 2 minutes. So, and then don't only accept from the nurses and from history, from residents, they say, well, it's a bolus feed. Now you have to go to details. So if it's 20 minutes, that's what I call it bolus feed. It can be gavage feed, of course. And then it can be continuous feed all over the period, and it can be intermittent continuous. The type of the milk also affect formula, non-formula, additives, and so on. You need to make sure that when you have apnea related to feed, you need a detailed feeding history. So, and now we're talking about pathogenesis. Rola, we have to stop after 45 minutes and then take a break and then continue. So if you just time me, please, because I might forget. Now, with the pathogenesis, the explanation of apnea of prematurity are very wide, and simply it is unknown because there are many clinical conditions contributing to it. But broadly, can we say it's because of the immaturity of the respiratory drive. Also, the problem with the peripheral receptor, and it might be due to reflex, and it might be due to respiratory muscles, and there are other factors contributing. So I would say most of the biggest share of factors that cause immaturity is the immaturity of the respiratory drive. Because it's been approved that apnea occurs when there is brainstem malfunction. And also, as an indirect clue, we know the apnea occurs more frequent and more severe with lower gestational age, and we know that the brain function conduction time is also low with the lower gestational age. So indirectly, we assume that immaturity of the brain stem can lead to apnea. And we know that breathing is affected by sleep. And we know that during active or rapid sleep movement stage, there will be irregularity of tidal volume when the patient is on ventilator. And we know the stage of rapid eye movement of the sleep are predominant in premature baby. And we know that the apneic spell are more frequent during rapid eye movement stage than the quiet stage of sleep. So from all these factors, we know that immaturity of the central respiratory drive is a big contributor to apnea of prematurity. Now, also we have the chemoreceptors, because you remember we have ventilation and we have perfusion and oxygenation. Now, how the brain know that there is hypoxia or the oxygen going up, or how we know that we have hyperventilation and the CO2 is going down, or there is hypoventilation and CO2 is going up, the brain need to sense it, and how these gases in the blood being sensed is by chemoreceptor. Okay, we know that when the patient or the baby or the premature baby become hypoxic, they become less responsive to increased carbon dioxide level. And therefore, we know because of that, immaturity of chemoreceptors may be involved in the pathogenesis of apnea. Although most of infants will not be hypoxic before the onset of apnea. So somebody can say, oh, maybe no, there is no contribution of chemoreceptors. And even if it's contributing, maybe it's a little bit, not as contributing as a respiratory drive. And the reason because there is no hypoxia before apnea, though the apnea appear. Yeah. So, well, after the apnea appear, the chemoreceptor might, because improper response of premature baby, the chemoreceptor might prolong in the severity, how down the number is going, and how long they are lasting. So chemoreceptor might contribute after the apnea start because of the immaturity of the respiratory drive. Now, the ventilatory response to increased CO2 decrease with premature baby. When you do a comparison with term babies and adult, between premature, their ventilatory response, instead of increasing, it becomes periodic rather than increasing. It is the same when you go on high mountain in adult, and also it might pause the breathing instead of rapidly breathing. So, and that's why from that point, we think that chemoreceptor might contribute to the pathogenesis of apnea. Now, I'm making it very simple, but it's a little bit more complicated than that. We know that babies have very lax respiratory cage, We know that ribs are not very strong, so we don't have a starting point for increasing and decreasing the chest and chest size and creating the negative pressure within the chest to inflate the lung. So we know that it's lax, and we know that we cannot use, for example, compliance and resistance when we ventilate because of that, in addition to the leak. So we know that the diaphragm and intercostal muscle are not working very well. We know the diaphragm cannot achieve very well because most of the babies are abdominal breather. They use the abdominal muscle to help them, and they use accessory muscles. We know that the muscle of the upper airway, the larynx and pharynx, are very lax and soft. We know that upper airway obstruction cause or contribute to the apneic spell. Okay, and we know the tightness or the stenting of the upper airway become less in rapid eye movement stage. Because remember, when you have apnea, you give CPAP. One of the reasons why CPAP improve apnea is you stenting upper airway. Once you stent upper airway, you know the apnea, and you know if it's obstructive, it's improved. Okay, we know passive neck flexion or pressure on the lower rim of face mask can cause apnea. Okay, so we know that obstruction can cause also to lead to central apnea. We know that spontaneous airway obstruction is more common in preterm babies. We know that nasal obstruction can lead to apnea. And so, and we know when the nose are obstructed, the babies start to breathe from their mouth. So from all that reason, we know the respiratory muscles are a contributor to the apnea. The respiratory drive, the central respiratory initiation as I said, of the initiation of respiratory effort change with the change in the level of the CO2 and oxygen. And that change also change with the gestational age. And we know that the respiratory drive depend on the neural output and the chemoreceptor output. So the respiratory drive affected by the chemoreceptors and affected by the respiratory muscle. And we know that the respiratory drive is the integral part between the chemoreceptors, the neural sense, and the respiratory muscles. And there is efferent and afferent pathway can affect both sides. Now I'm going to pass this. I don't think I need to go all these details, but we know that there is upregulation and downregulation of a neurotransmitter, depend they are inhibitor or not, like adenosine, GABA, and endorphin, and therefore we use adenosine. That we use the caffeine, which inhibit the adenosine in the because they have inhibitory neurotransmitter upregulation. So I'm going to pass this. I don't think I need. I already talked about it. Yes, I think I talked about all this. Okay, I'm going to pass this. Now, I want to speak when we talk about respiratory drive, what will happen when, or what is the response, or what is the change in the central respiratory drive regarding the CO2 is going up. So, and we know that the CO2, whether in adult or pediatric or newborn babies, are important to drive for breathing. However, in newborn babies is more important. The newborn baby depend more on CO2 too. So if you see apnea and you're ventilating a baby and you're washing CO2 and you want an extubate patient, but the patient is not breathing when you give a CPAP trial or you put the patient on PSV, probably because your CO2 is low. So what you have to do is you have to lower your parameter to build up some CO2 to stimulate the brain, because remember the CO2 for respiratory drive is way important than oxygen in newborn babies. So it is vital to remember the hypercarbia might be as a result of apnea because you have no ventilation, but also it might contribute to the apnea. So you need a little bit, and therefore now we're changing the term. We before used a term normal blood gas level, and now we remove that normal. We say acceptable or permissible levels. We don't say normal, because that normal level change depending on the gestation, depending on post-gestational age, depending on the condition, the depending amount of respiratory support. So remember, hypercarbia is important, a result of apnea, but it's also important treatment for apnea because it stimulates the brain. And how to stimulate the brain? Through the chemoreceptor, whether it's a peripheral or carotid or aortic bodies. And the response to inhaled CO2 are very blunted. That means is under certain level, there is no response. After certain level, there is complete pause of. So if you go up, then start to stimulate until you go to a certain level, the baby stop breathing. So it's important to remember it's very blunted response. And there is this response change. And the incidence of apnea and the response to CO2 even lower with going to the lower gestation, lower with the low birth weight, and lower with the smaller gestational age. So always you need to remember that. And why this changes, or why there is a ventilatory response change to CO2, it's because of change in respiratory drive, chemoreceptor, and pulmonary mechanics. Now, I have done a workshop or a course about ventilation. It's on YouTube, and it's about like 15 sessions. But you have to know that neonatology been revolutionized after between 2007 and 2010. Before 2007, we used to depend on blood gases. But after that, we have the graphics and loops. And the graphics and loops, because they are dynamic, because they are continuous, because you can observe them, they are very great tools. And because we know that graphics and loop can measure pulmonary mechanics, then it's vital when you have a ventilation problem. And when you say ventilation problem, we're talking about CO2 level. Therefore, CO2 or the response to CO2 change with change in the respiratory drive, if there is a medication, for example, or there is an obstruction followed by effect on the CNS more than 5 seconds, or because of change of pulmonary mechanics, resistance and compliance. Hypoxia, it's lots of text. I don't want to bore you with the text, but the response to hypoxia almost always depend on the chemoreceptor, the peripheral chemoreceptor, whether in the peripheral blood vessels or in the carotid body. If that chemoreceptor is immature, the response to hypoxia is blunted. And because of that, we think that the response of a premature baby to hypoxia is biphasic. So at the beginning, start to increase breathing, but once you increase the breathing, you start to wash CO2. Once you wash CO2, you go to hypoventilation. Sometimes you go for apnea. So get hypoxia, get peripheral stimulation, you get rapid breathing, but CO2 washed, then you get hypoventilation. So we call this biphasic response. And this immature biphasic response can go up to 38 weeks. Very unlikely to occur after 38 weeks. Okay? And this is, we think that sometimes it goes below, after 38 weeks corrected age, when the baby is very premature, like born at a gestational age of 23 or 24. Okay, so I'm gonna pass all the other text, you guys can read it, but that basically is, I can answer the questions after. Ayman, you can ask the question after the session. So the other, surprisingly, maybe surprising to some of you, but not for me, is hyperbilirubinemia. Hyperbilirubinemia can contribute to, there is evidence, although it's not clear. Okay, okay. So I'm stopping here. So let's take break. You can ask question, you can drink tea, okay? And then we'll resume after 15 minutes. So right now is 4:45 and I will resume at 5 p.m. Okay? So I'm gonna bring just tea and come back. If you have a question, I will answer it. So I want your feedback. Am I fast? Am I slow? Is my tone high? Is my tone low? Am I clear? So any comment about my performance? Do you want me to be slower? Do you want me to be faster? Do you want me to, any suggestion? I'm happy to hear. So let me stop the sharing and then you can see me. Okay, so I am back. So let's look at the questions. So a question from Ayman Ayman or Ahmed. Okay, I want to ask if SpO2 below 94, mild hypoxia. Well, first, below 94 is not hypoxia. The term hypoxia, when you have 25% of, or 5 gram of hydroxy, of carboxyhemoglobin. So below 94 is not. Below 90 is not hypoxia. That is called desaturation. Now, the definition of starting desaturation varies. And if you look at the support trial, there are 2 levels. But the accepted level, I would say, somewhere between, in a premature baby, somewhere between 91 and 94. But if below 90 is significant, but more serious if less than 85 with cyanosis or 80. And so again, it all depends, subjective definition. So I would say until 85 is desaturation, not hypoxia. I would say if it's above 85 and prolonged and associated with the brady, or I would say it is hypoxia. And if it's more than 85 and you see cyanosis, then probably it's a measurement problem. And my best would use nurse to make sure that these numbers are correct. Because as you know, the pulse oximetry have many drawbacks and have many artificial issues, contact and vibrations and light are all affected. Are you Ahmed or Ayman? Because Ayman Abdul Mati Dana, and I know Ahmed Abdul Mati Dana.
I think they are related. Maybe they are brothers.
Oh, I see. Okay. So hypoxia
Yes, we are
usually.
brothers. Sorry, we are brothers actually.
Oh, you're brothers. Oh, nice to meet you.
Yeah.
Okay.
Yeah, I'm a family physician.
Oh, I see. I see. Well,
and I give you this protocol according to the adult. When you are usually we are receiving any patient, you're dealing with this like that, like with adults. So I'm asking.
So let me tell you something. The saturation level in a term baby should be more than 94. In a premature baby, it's not. In a normal level, in a premature baby, down 88 is acceptable. But persistently, now there is a support trial where they have 2 arms between 88 and 91, and 91 and 94. Now, between 88 and 91, you have less ROP and you have less chronic lung disease, but the death rate was higher. Between 91 and 94, the death rate was less, but ROP and chronic lung disease was a little bit higher. And because of the death rate, they stopped the trial, and then most of most of the centers use normal level 91 to 94. Now, if the saturation more 94 and you are on a room air, and all is good, but you don't need to start oxygen unless you go below 91. And I would, thank you very much. And I would go for first for respiratory support before I increase oxygen. And I hope I answered your question. Ilham said it's beautiful. I enjoy it. Thank you very much. Ilham again. Ahmed, you say I love it. Thank you very much. Oh no, it's not for adult. Adult looks like a time baby. And Kamal, well, I need to hear about my fellows. Where is my fellows? Where are they? Anud, Muna, Yaman, Yaman, where are you? Are you with me? Let me unmute Muna. Muna?
Yeah, yes, doctor.
Any comments? Well, first, I missed you. It's been now 2 months. I didn't see you.
Yeah, we miss you a lot.
Any questions? Any comment? Am I fast? Am I slow? What do you think?
No, it's the pace is going very well. I can follow, but I'm just busy in between because I'm on duty.
Oh, I see. Okay. Well, I'm recording it, so I hope, and because it is related to Ministry of Health, so it's not mine. So I will ask the TDC to post it somewhere or in a share folder so you guys can review it. But I'm recording it, so you can review it many times. And I have task for you to Dr. Mona, and I have task for Yaman and another task for Yaman to go more in depth of apnea at the end of
Yes.
this.
Sure.
Yeah. So I personally want you to critically appraise the CAB trial. But we're going to talk about the session when we end the session.
Okay, sure.
Okay.
Sure.
Where is
Thank
Anud?
you.
Anud? Is Anud here? Anud?
Yes, I'm here.
Yeah.
Yeah, Anud. How's the session? Do you have any question? Anything?
No, not really.
Inshallah. And I want you to critically appraise the support trial and especially the oxygen level. Like what is the accepted oxygen level? We will talk about it. I want you to read and critically appraise the support trial. And we can do it together, inshallah, but at the end of the session. So let's see if I have a question from Ilhama. Thank you, Anu. Thank you very much. But Yamin is not here, right?
No, Yamin is here.
Where is Yamin?
I can see him, but he's mute.
Yeah,
Hello?
where is he? Where is Yamin?
Hello.
Yamin, Habibi, وينك? I missed
I'm
you.
with you. I had some disconnection in the break, but I came back now.
Oh, okay, great. So did you hear the session or you didn't hear it?
No, I was with you from the beginning.
Oh, okay. Well,
Alhamdulillah, it's
okay, I will give you the toughest job because you are male, and
no problem.
so I will give you the toughest between them. I will give you some task to do. So I have
No problem.
Thank you very much. So I have a question from Ilhama, Dr. Yahya, regarding hyperbilirubinemia. You said it caused COS. What is COS?
She means it causes apnea. Can I ask about the pathophysiology of that? That was her question.
Yeah, it causes depression of respiratory drive. It affects the performance of the respiratory drive. So when you have a jaundice preterm babies and you have apnea, you need to treat it. But I don't have a clear evidence, but there is an observational study. But what is the chemicals that is being released from the bilirubin causing depression of the respiratory drive? I am not sure. I don't know. But it is there is something, either the bilirubin or it's one of its metabolites can cause depression of the respiratory drive and contribute to them. What is the target? We use in our unit, and here people with me, they can correct me if I'm wrong. We use between 91 and 94. Isn't that right?
Less than 95, yes.
So between
90 to
91
95.
and 94. So we, and then we put the alarm, I think, between 85 and 95.
Mm.
I think that should be, and that goes with all the evidence, current evidence. I personally, 5 years ago, I was between 88 and 91. But when the trials show that the death rate is higher, we've changed the level. Any more questions? Any more questions?
No one is writing anything.
Okay. Well, we'll give you 5 more minutes and then we'll start.
Open them up. Hello.
Anyone?
Hello, yeah, Doctor.
Who's talking?
Yeah, me, Ilhama.
Ilhama.
Yeah, you can hear me because my mic was not working before. Yeah, Dr. Yahya, regarding, that's why I type it, it's mistyped. Regarding you told this hyperbilirubinemia cause apnea, right? Does it matter?
I didn't say it cause apnea. I didn't say that.
One of
No, I didn't say it cause apnea. No way. I think you're missing.
the slides.
There is 3 factors I talked about: hypercarbia, hypoxia, and hyperbilirubinemia might affect the respiratory drive.
Oh,
And
my.
respiratory drive might contribute to apnea. Okay, but there is no direct link between hyperbilirubinemia and apnea. I didn't say that. So we need to be careful.
Okay. Okay, maybe I didn't say. I said another question regarding a preterm baby. We say that hyperventilation, low CO2 can lead as well to apnea.
Yeah. So I'm going to ask you a question.
Yes, please.
You're Muslim, right?
Yeah.
So if you're fasting,
Yeah.
and I give you sugar and TBN as IV, would you like to eat? You didn't try it, no, but mostly no. So let's go to CO2. If I'm washing CO2, your CO2, because you're part of your why you are breathing is because you want to wash CO2. You want to take CO2 out of your body.
Yes.
So if I take your CO2, you need to breathe.
Yeah.
You don't need to breathe because I'm taking your CO2. That's why low CO2 causes apnea. Another way,
take my CO2 out, as you said, I have.
If you know the high frequency jet ventilator, if you go back to the history, and I love history of medicine, and you look to the Banal who discovered the frequency jet, how he discovered it? He discovered it by chance. So he was having a bag and he put a rabbit, a bunny inside the bag, and he was ventilating, he was moving the bag, okay? And he was giving the breathing 40 or 30 beats per minute. But all of a sudden something happened, mistake, and it got very fast, very fast, by mistake. And then he went and came back and saw the rabbit was not breathing. So he thought the rabbit was dead. But he did a blood gas on the rabbit and he found it normal blood gas. So he thought he was ventilating the rabbit for some way, but he didn't know how. So after 15 years, somebody from Ontario, and he's not a physician, he is a computer guy, and he was chatting with his friend at a hotel, and he told him, I can tell you why. Okay, because you're causing the disturbance of the floor, you know, the pavement, or the theory of the ventilation. Which means, in another way, because he was ventilating the rabbit very rapidly, he washed all his CO2, and therefore the rabbit was not breathing. So washing CO2 can cause apnea, and therefore when you have hypoxia, the baby, all the baby, they will start to breathe fast. Once the baby start to breathe fast, they will wash CO2, and that's why it causes apnea. So that's why we call it biphasic response of premature baby to hypoxia, and it's different from adult. And it's exactly the same response when I put you on high C level. You will get periodic breathing and then you get apnea. If the oxygen goes below certain level that you cannot tolerate. Yeah.
Very beautiful. Thank you.
Did I answer your question?
More than expected. Thank you very much.
So let's restart again.
لا في question من دكتور أيمن.
Okay, go ahead, Ayman.
في كتب لك question. There is a question written.
لحظة بس لحظة خليني أشوف. Thank you. Chat. Where is chat? Where is the chat?
Hypoxia usually is acute setting.
Hypoxia usually is acute setting, but hypercarbia in a chronic lung disease can give example in which cause hypercarbia will.
In which cases hypercapnia will be our target instead إنه hypoxia.
I did not understand the question, but I think you misled probably because now you are not neonatologist and you misunderstand. What I'm trying to say is.
No, I'm asking usually chronic lung disease. I'm not a neonatologist. As I told you, I'm a family physician and I was working as an internist before.
Mm-hmm.
So usually our target, we are not taking the hypoxia. Usually are taking the hypoxia as the first our target and we are trying to correct it. But when it is hypercapnia, usually in neonates or preterm, that means that there's no acute settings. It should be chronic problem. So when it will be apnea in a neonates or in a preterm, that you can see the hypercapnia is the drive. So you are targeting the carbon dioxide instead of oxygen. That's my question.
Let me speak about it at the end of the session. I am not 100% sure I understand the question, but I will try my best to answer it at the end of the question. So because we passed the time by 2 minutes, so let's restart the session and I will answer at the end of the session. Okay, so we already talked about hyperbilirubinemia. Now we've talked about respiratory drive, we talked about chemoreceptors, we talked about upper airway obstruction. And when we've talked about respiratory drive, there is other factors. Let's say these factors cause apnea, and kindly mute yourself. Rula, you can mute everybody. I think you're a manager in the meeting. You can mute them. So there is something called gastroesophageal reflux. It's a very common in preterm babies, and there are many reasons why it's common. And we know that there is association between feeding and reflux and apnea, and that's why we know that the gastroesophageal reflux might be contributing. Also, in addition to the respiratory drive, we know that there is many other neurotransmitters have a role in apnea. We know that collapse of the upper airway might contribute to the apnea. We know that upper airway might be causing apnea by inhibitory effect of chemo. We know nasal obstruction might contribute to apnea. We know some laryngeal and tracheal variation might contribute to apnea. I will speak about that, Ahmed, at the end. Okay. So how we monitor and how we evaluate apnea? Now we know all the babies in the NICU, before they go home, and usually they go home when they are 35 weeks, they should be on the monitor. When we say monitor, it's a cardiorespiratory monitor and it's a pulse oximetry. Now some people use NIRS, but this depends on the availability and logistics. And when we stop, we should be at least 35 weeks, and we should be at least 3 to 5 days of apnea. When we talked about apnea and monitor, sometimes they do not catch up all the apneas. And the reason because we use the impedance. We use something called RIP, respiratory inductance plethysmography. And the RIP is changing or measuring the percentage of change of chest diameter. And therefore, it might not be within the limit of the percentage of changes of chest diameter. And sometimes the monitor will not pick it up. Okay? And therefore, pulse oximetry is vital with the apnea monitor. So sometimes you see apnea, but the oxygenation is okay. So probably it's an artifact. Sometimes you see desaturation without apnea, and probably the monitor apnea monitor is not picking it up. But again, it depends on the impedance. And sometimes, surprisingly, they are very prolonged spell, and you don't recognize them. Okay? Remember, the monitors are not there to be monitored. They are there to give us alarm to act. And if we don't act, then probably there is no need for monitor. And when we act, we should check for causes, central and obstructive. And we should check for apnea consequences, which is bradycardia and hypoxia or cyanosis. I would say 90% of apneas responds to tactile stimulation. And when we say tactile stimulation, we're talking about stroking, not hitting. And when we say stroking, only the limbs, not the body. Remember, if you walk in a street and you see a muscular guy, and then you see another weak person, when you fight that weak person, you fight with him lightly. But when we fight with a muscular guy, you should be very tough. So being tough with a vulnerable creature like Britain will not help. If the baby is not responding to simple tactile stimulation, he will be not responding. He needs ventilation. So most of the babies will respond to tactile stimulation, but simple one, stroking, not hitting, not squeezing, not crushing, not compressing, just stroking. And when we say the places, only the peripheral, not the back, not the chest, not the abdomen, not the head, it's just the limbs. So if patient fail, then you need respiratory support. Remember that. If you have one apneic episode, you have to evaluate the baby for correctable causes. We know the most common is physiological apnea of prematurity, but correctable causes are vital. What is it? Hypothermia, hypoglycemia, IVH, obstruction, respiratory problem, infection, metabolic, and so on. You need to check. And you need to be very alert if you have an apnea after 34 weeks. Your evaluation should include history, and then physical examination. You need also investigation sometime. You need a blood gas to make sure that your CO2 is not low. And you need a complete blood count to give you an indication of the hemoglobin and evidence of infection. You need glucose, calcium, electrolyte. I hate CRP. Who works with me, I don't like it. I won't measure it. Although sudden infant death occurs more frequently in a preterm infant, history of apnea of prematurity is not associated with SIDS. And it's not a risk factor SIDS. Hence, home monitoring is not advisable. So how we evaluate? We evaluate for infection, we evaluate for oxygenation, we evaluate for metabolic, drug, temperature instability, intracranial problem, and CNS nervous system issues. So how we approach? First, we look for maternal and neonatal history, especially if we are still within 1 week of life. Is there any magnesium sulfate as a neuroprotector or opiate? Is there a risk factor for sepsis? Is it the delivery is traumatic? Is there perinatal asphyxia? Is the mother diabetic, risk of hypoglycemia, and so on? Sign and symptom of hypoglycemia, symptom of sepsis, sign and symptom of neurological impairment due to intraventricular hemorrhage or hydrocephalus, or even encephalopathy. By the way, I want to ask, what is encephalopathy? Anybody can define it to me? It's very interesting because I know many people don't know what is encephalopathy. Any of the fellows, Anud, Muna, and Yaman, one of you define for me the encephalopathy, not neonatal, encephalopathy in general. Anud, Muna, and Yaman. Any volunteer?
Can I say if I?
No, you
if,
cannot.
we can say,
only my fellows.
okay.
Sorry. My fellows? Any volunteer? No? Muna? Dr. Muna?
Yeah, من عنود Muna.
Are they there or they run away?
I can see them still there, but they are mute.
Unmute them. Unmute Muna. Ask Muna.
Muna.
Okay. Well, we'll give them this as homework. What is encephalopathy? Okay. Also, you look for sign and symptom of necrotizing enterocolitis, and consider also there might be malformation or upper airway problem. Feeding. It's vital to have detailed feeding. Don't go just, it's a bolus feeding. We need to know exactly the timing. We need to go on amount, the additives, the way we give the feed, the position. Don't say only gavage. You need to know the level. So you need a detailed history. Okay? And especially the relation between the feeding and incidence or the timing of the apnea. Laboratory evaluation you need, we talked about, we need complete blood picture, we need culture, we need metabolic electrolyte, calcium, glucose, we need a blood gas, we need maybe we'll check inborn metabolism, so we can do blood gas, we can do ammonia level, we can calculate the anion gap, we can also do serum amino acid, urine organic acid. You can ask for acyl cholinesterase level. You can check for FAO disorders and so on. It might be you need an imaging, and it depending on whether it's a gross or it's a cellular level of damages. And then you select the imaging mode. You can use an ultrasound or CT scan or MRI. Mostly ultrasound is enough. Now, what is the treatment of apnea? Well, we have the general measures, general supportive measure. We have the caffeine, our first and the most important defense. We can use respiratory support, whether it's a CPAP or non-invasive, blood transfusion, treatment of things related to ventilation, treatment of the cause if available, and at the end, if there is no solution, the ventilation is the last castle that we go. So what is the general measure? The general measure means finding and treating the cause, optimizing the oxygen, optimizing, somebody's texting me.
بعدين.
Okay, so is the caffeine preventive or a prophylactic or a treatment? Now, this is debatable. The reason because apnea of prematurity is a physiological. It's not something you prevent. But yes, we start caffeine as a preventive measure without apnea. Because, babies below 28 weeks, almost always 100% they will get apnea. So is the considered this is prophylaxis or treatment? I don't know, and that's why we don't mention it. So you supplement oxygen, you wash CO2, you avoid reflux, you do sometimes suctioning, avoid deep suctioning though, positioning, having the baby in universal flexion, do nesting, comfort care, and so on. All these are measures can help to treat apnea. Environmental control the temperature, control the humidity, head and neck positions are all these. Now we come to the caffeine. Now the question, the caffeine is a treatment or it's a prophylaxis, and it is somewhat a percentage of both. Well, we know by evidence that methylxanthine reduces the number of ventilation for apneic spells. The primary mechanism, it is antagonism of adenosine. It's a neurotransmitter. The adenosine is inhibitory, and it's an inhibitory neurotransmitter. It is upregulation inhibitory, and therefore inhibition, it becomes positive. Okay, and it works by inhibiting a receptor called alpha-1, which is the inhibitory, and the excitatory alpha-2A receptor. However, the caffeine has other factors or other actions. So it increases carbon dioxide sensitivity. It decreases hypoxic depression of breathing, and it decreases the periodic breathing. It also has some enuresis effect. It increases urine output. It also has some strengthening of the diaphragm and muscle and the respiratory muscle. So there are many, but the main is inhibitory of adenosine or antagonism of adenosine as a neurotransmitter in the respiratory drive. Now, several trials. The famous one is CAP, and I want Anu to critically appraise it, but this is the basic of use of caffeine is the CAP trial. Okay, so we know from this CAP trial that the premature babies with caffeine survive without neurodevelopmental disability by Bailey assessment at 2 years as a primary outcome compared to the placebo, but also have secondary outcomes such as decreasing the rate of bronchopulmonary dysplasia. And therefore, it's advisable to start caffeine for any babies less than 28 weeks and less than 1,250 grams. For those more than 1,200 grams, 1,250 grams, or more than 28 weeks, and you need some respiratory support or you need mechanical ventilation, probably you need to start caffeine. Should I continue caffeine? Who's not muting himself?
I think they are on mute.
Okay. So should we give caffeine during mechanical ventilation? The answer would be yes, because of the other, not only inhibiting the adenosine, because the other way of action of caffeine. Okay.
Yes.
So I'm not going to go, all of you know, the loading dose of caffeine straight, half of it, if it's base, you give it over 30 minutes, then followed by maintenance dose, and should start after 24 hours. You probably, if the apnea continue, you can give mini load or half load, being called here in UAE.
Yes.
And we need the serum level to be 5 to 20 because the therapeutic range is very wide. Usually we do not measure it. So we don't measure the caffeine based on that. Usually the caffeine should be stopped between 34 to 35 weeks. However, sometimes you need to continue beyond that if the baby was born very premature. Now, even if you are 34 and 35, there is other condition. The baby should have no apnea within 5 to 7 days. And that usually not happen until sometime even up to 42 weeks. So the baby should be more than 33 weeks, but also free of apnea between 5 to 7 days. What is the benefit of continuing caffeine is uncertain. So let me ask my fellows again, what is the maximum dose that can be given from caffeine to the baby? Muna, Anud, and Yaman.
Maintenance or reloading?
Maximum whatever dose you can give, whether maintenance or loading. What is the maximum and why?
20 milligram per kg, the loading, and the maintenance can go to 20 milligram per kg. Loading, sometimes they use 30 milligram per kg. That's what I know. Yani.
Okay. And what happens if you exceeded 30? You said 30. What will happen if I give 50?
The side effects of caffeine will show, yani tachycardia, diuresis, these things.
So if the baby is not ventilated and have a little bit of tachycardia, who cares? If I give 50 and he has a little bit of tachycardia, but I avoid intubation and ventilation, I think all is good. What do you think?
It's actually, to be honest, yani, I don't know if the caffeine will be effective after certain dose.
Oh, I see.
So I'm not sure about this information.
Okay. Well, if you think it's not effective, then probably it will not cause tachycardia, right? Because it's not effective. So
Yeah,
why?
that's I'm telling you, I'm not sure. Yani, after certain dose, it will be that effective.
Yeah. Okay. Let's ask Yaman. Yaman,
Doctor,
what do you think? What is the maximum possible dose? And what happens if you give it after the maximum possible dose? You have idea?
well, I have no exact idea, doctor.
Okay. Muna. Tora Muna.
I think Mona is
Not here. Okay. So the maximum dose that I know is 80 milligram per kg per day. Okay. And after that, we think that it will cause toxic manifestation. And when we say toxic means you're damaging the body, you're injuring the body, you're causing poisoning. Okay. And what is that poisoning? Is seizure, Dr. Anud. So we're looking to CNS manifestations. It can cause seizure and it can cause death because of the seizure. And that's the reason why you don't go higher level. Now, what will happen between 20 and 80? I am not sure. There are trials that people use 40, 30, and 50. But if you give a baby accidentally higher dose, you're looking for seizure and maybe death. Some people, they say, might cause renal shutdown, but I'm not sure. I know in higher dose, it can cause seizures, pausing of breathing, and maybe death. When you reach more than 80 milligrams, but if you are below 80 milligrams per kg per day, you probably are safe. So Muna Arula is saying, we do continue until spell resolve or until the baby is off of any kind of respiratory support. 80 milligram interrupted dose, or no, it's total dose, 80 milligram total dose. Once it can be interrupted, it can be one dose. Total dose, 80 milligram per kg per day. Now, do we continue? Or yes, of course we have to continue. You should never stop in your respiratory support. You should be on room air. You should be more than 33 weeks, and you should be off apnea for at least 5 to 7 days. So if you are, let's say you are 42 and you are still on respiratory support, but you are on respiratory support, not oxygen supply, because sometimes you're breathing, but you need a little bit of oxygen. So in that case, you can stop. But if you need respiratory support, then probably you need still caffeine. Okay?
okay. Yeah, clear.
What else? Long-term benefit and risk of caffeine is uncertain. In CAB trial, there is they were randomizing and there is no clear evidence. There was no effect on the growth parameters. Most of the side effect of methylxanthine is based on anecdotal stories. There is no evidence, it's all on experience. Okay, and any caffeine level less than Thiophyllene toxic level is well tolerated. And I know the toxic level is 80. So anything below 80, I'm not sure why 20. I think if there is a little bit of tachycardia and you prevent ventilation, I think I would use it. The problem is all the sites said 20, and if you use a 20 and if something happened to the baby, they will blame you. So maybe that's the reason why people don't go more than 20. So when we are 45 minutes, stop me. Caffeine side effect, well, tachycardia, you said. Huge instability. It might cause some gastroesophageal reflux. It might cause some delay in gastric emptying. Okay? But it never have any clinical significance. You know, never heard that there is tachycardia caused by, for example, heart failure. Okay. We know that the metabolic rate and oxygen consumption also increase with caffeine, but that's not been observed to decrease the weight or the need to higher nutritional supply. Okay?
Yes.
Okay.
Yes.
So what is the long neurodevelopmental effect of caffeine? There is very limited diet. We have the CAP trial, we have the support trial. And they said that there is probably a benefit, long-term neurodevelopmental benefit of using caffeine arm in comparison to the placebo. And they think that the cognitive ability at age of 5 and 11 years of premature baby is better than the placebo. Okay, not only the neurodevelopmental, they think that the fine motor coordinations, the visual motor integration, the visual perception, and visual spatial organization, and when we say visual spatial, we mean 3D. Visual perception is the 2D. So visual spatial orientation or organization is better in the caffeine arm. Okay. However, we're not sure, but we know it is very safe on long term. It is very safe regarding the side effect. So it's safe when you use it for a long time. So even if you don't cause benefit long term, you will not cause harm on the neurodevelopmental outcome. Now, is it caffeine or thiophyllene? Anybody? My fellows, do you want to answer, Yamin?
Caffeine.
Caffeine, why?
You don't need to go monitor the drug level.
Correct, because?
And less side effect because of wide variability.
No, because of margin of safety. The difference between the toxic...
Wide therapeutic index.
Yes, because the difference between therapeutic level and toxic level is very small in thiophyllene. While it's very wide, it's almost double in caffeine. That's one. Second is the percentage of enteral absorption of caffeine is more reliable than caffeine. And that's why it's advisable whenever thiophyllene is indicated, caffeine is indicated. However, thiophyllene is better a bronchodilator, and it's better diuretics. And therefore, it's preferred in asthma attacks. Okay?
Yeah.
Well, let's talk of continuous on CPAP. Now, although it said here 4 to 6, I won't advise 4 to 6, but sometimes you need to do 4 if you have you just need to stent the upper airway, because it helped way better obstructive apnea. It also helped way better the mixed type of apnea. Because now if you have, you want to wash CO2 and you want to use non-invasive ventilation, so it's probably not the CPAP. You should non-invasive ventilation. You need some breath. So people always ask me, should I still use a plain CPAP or use advanced CPAP? Should I use CPAP or use BiPAP? Now it depends on the CO2. If your CO2 high, you need BiPAP. If your CO2 is low, there is no point of giving non-invasive ventilation. Now I know Ahmed is very adamant in using non-invasive ventilation, but I don't see the point, because the point here is you're stenting the upper airway. And to stent upper airway, you need to consistently stent upper airway. However, somebody can argue that when the baby breathes out, you don't need that pressure. Yes, that's true, because you're using the generator. You're using fluidic flow principle. You're giving variable flow CPAP, not a continuous flow CPAP depending on the expiratory valve. So using CPAP is way better. A plain CPAP, one level CPAP is way better than non-invasive. And you can just avoid CPAPophobia. There is no problem of giving CPAP of 20 if the baby tolerates and if it's a few days after. CPAP is not a problem. Instead of nasal mask or nasal prong, you can use a humidified high flow nasal cannula. They say something that although I prefer the CPAP, non-invasive ventilation also can be used if you have apnea with high CO2.
It's 5:30 now.
5:30, so we have 30 minutes to go, right?
Yeah.
So do we treat apnea with transfusion? Now, yes, we can give transfusion because we think anemia can cause apnea. However, it's been said transfusion will not improve apnea. Now, what I do is if you have a respiratory support and it's less than 1 month, I would transfuse below 12. If it's without respiratory support, I would transfuse below 10. If it's more than 1 month and we are on respiratory support, I would transfuse below 10. And if it's no respiratory support, I would transfer below 7. So this
I have a question, Dr. Yahya.
Yes, go ahead.
Regarding now, shall we depends more on the hemoglobin level or on hematocrit?
No, hemoglobin. You should never depend on hematocrit. Hematocrit is two factors, the RBC and the concentration, while the hemoglobin is measuring the amount of material available to carry the oxygen. So no, you never depend on hematocrit. Never. It's absolutely wrong. You depend on the hemoglobin. The hematocrit, you use it when you have polycythemia. And the reason why, because of coagulability. So I use a hematocrit to look at dehydration, and I look at compensation or do partial exchange, but I will never use it when I am looking for oxygen. My aim is to deliver oxygen, and the carrier, the car of the oxygen is the RBC. And what is carrying the oxygen in the RBC is the hemoglobin. So it's not a hematocrit. Hematocrit measure the relation between the hemoglobin and the fluid and the amount of volume of the blood. So no, not the hematocrit.
Okay.
So how you discharge the baby? As we said, more than 33 weeks, no respiratory support, 5 days to 6-7 days.
Of caffeine and no apnea space.
Of apnea. Of no apnea, and then you stop the caffeine. Now the problem is we know that the life or the half-life of caffeine is almost 100 hours, and therefore you should not send a baby after stopping caffeine until 5 days pass. At least 5 days, 5 to 7 days. When you're busy, you go to 3 days. 3 days is 72 hours. So 5 days, 4 to 5 days is the beautiful. After cutting, if there is no apnea, then
discharge baby home.
If the baby cannot stop, or you stop and resign, you can continue and send the baby on caffeine. And then after 1 month, you do a respiratory sleep study, and it tells you whether you are obstructive or you are a mix or you are central, and then you can decide to continue or not. Okay. Now, if the baby has apnea, feeding related, you can still stop caffeine. Okay. You always need to monitor the N according to CHIMI trial, and I need somebody to do critical appraisal for CHIMI trial. Now, intercurrent viral illnesses, anesthesia for surgery of premature baby, ophthalmological examination, vaccination, all can affect your decision to stop the apnea, stop the caffeine. Okay, so sometimes you can go up to 44 weeks and you can discharge baby on caffeine. So what is the use of respiratory monitor? There are lots of text, but the nutshell is it's not usable because it does not prevent or decrease the SIDS of the respiratory monitor. The only things we'll do, because there is lots of artifact, and it's the only things that it will do is stressing the parent. So it's not advisable to use, whether with the old technology or new technology, wireless to use a cardiorespiratory monitor at home. I'm not going through, but it's not advisable. So take home message. Apnea usually resolve at term. Sometimes it goes to up to 40 weeks when you are a premature baby, or very premature. Caffeine is safe and effective. Evidence does not support use of anti-reflux measure. So please, no Gaviscon. I know people love Gaviscon, like a Pepsi in the unit. You find all the babies. No use of pantoprazole. There is no use of pantoprazole, please. 5 to 7 days after discontinuing the caffeine, can go home. And you remember Eric Eichenwald? He visited us in the unit. He written a lovely document on apnea of prematurity in 2016. Okay, if you wanna, this is a link for it. You can read it. It is a detailed one. It's a very good one. And I am done. So I am ahead of the time, right, Rula?
Yeah.
Okay.
Like,
So let's ask the question. Let's answer the question. Although I did not answer, I've answered your question. And let's ask. Can I ask? Usually, caffeine cause reflux of lower? No. If you do a lab study, yes, but clinically it will not. So it will not affect the. It will not cause reflux. So do not stop caffeine because you think you have reflux. Rula, I answered your questions. Oh, we do not use, I do not use inflammatory factors, Ayman. I don't use procalcitonin, I don't use CRP, I don't use ESR. I think the only advantage of CRP and other inflammatory factors is prolongation of antibiotic use. And we know prolongation of antibiotic use can cause resistance and can cause NEC. There is absolutely zero benefit of inflammatory factors. There is no evidence. The evidence are very strong against it. The only benefit in two situations, when they are negative, then mostly there is no infection. Second, and I'm sure when they are negative, people will not stop the antibiotics. Second, if your blood culture is negative, okay, and you still have a clinical patient has some signs, you're not sure it's due to infection. So serial measurement can help you to decide how long you go with the antibiotics. Okay? So these are the only two areas that I use. Just waste of blood, waste of resources, prolonged antibiotic use. It is absolutely useless. And the people who work with me, they know that I don't like them.
Okay, Dr. Yahya, then on what you depend when to stop the antibiotic?
Blood culture.
Only.
Blood culture, 2 sites blood culture, no clinical finding. I stop the antibiotics. What will happen? You are in an ICU. What will happen if you stop antibiotics? The baby will deteriorate. Do another blood culture, start again. It's always right to start antibiotics, but it's always wrong to continue antibiotics if blood culture is negative. I know people will say clinical sepsis, but that's an excuse to continue antibiotics. So if you have a high incidence of sepsis, if you, your high incidence of NEC, if you have a severe type of NEC, then you know that you are overusing the antibiotics. Because there is few evidence-based factors for NEC is breast milk and antibiotics. Those are 2 factors we know for sure they are the cause of NEC. We are accepting hypercarbia to protect the lung. That is incorrect way of phrasing it, Ahmed. We protect, we permit hypercarbia to not overventilate the lung, to protect it. So we don't do, hypercarbia has nothing to do with the protection of the lung. The question is, we do permissible hypercarbia to not overventilate, to not cause lung damage, and to protect the lung. So that's how I phrase it.
Dr. Yahya, just one question.
Because he asked me hypoxia is a cause, or acute setting, hypercarbia is a chronic. That is, Ayman, is incorrect. Both of them can be acute, both of them can be chronic.
Yes.
However, in chronic, you accept high level of CO2. In acute, you accept low level. But both of them can be acute, both of them can be chronic. But in chronic and acute, you need to accept same oxygen level. But in chronic and acute, you start to accept a higher level of CO2 or permissible level of CO2. Yes, ma'am, you want to ask me a question? Go ahead.
Yeah, Doctor, regarding for the antibiotic use, do you prefer to use the probiotic together with them or no?
Although this is not the topic, but it is a funny question.
Yeah, I know, sorry.
It's a funny question. I'm going to tell you something. I used to work in Canada in Winnipeg, and I work in two places, and they are separated by Red River. Okay? And we are the same team. We're the same people. The difference is the management and the nurses. In St. Boniface, they use prophylactic probiotics. In Health Science Center, they don't. We're the same team. So it's very variable. It is scary sometimes because there is no standardized dose, there is no standardized storing, there is no standardized vector, like how you give them through yogurt, for example. There is no standardized type, and there is no standardized age. And we know, there is a report, they can turn pathological at the same time. So when you are on antibiotics and the baby develops sepsis, I am not sure if that's due to probiotics or not. So I'm always scared of providing baby a live organism. Now, instead of antibiotics, you can provide the prebiotics, which is the food that probiotics use to make the antibiotics. So I personally against use of probiotics because the evidence are very variable. I would say is not convincing.
Thank you.
You're most welcome. Although it's not the topic, you went off topic.
Yeah, sorry.
I'm having a question, Dr. Yahya.
Go ahead.
As you mentioned earlier in your lecture that those who are delivered below...
It is a chit-chat.
Chit-chat, that those who are delivered before 28 weeks, they might still having apnea till 42 weeks post-menstrual age.
Correct.
So in case we stop the caffeine and they're still having persistent apnea, what to do? To keep them in the hospital, or we can send them home with special precautions?
Well, first, you don't stop if there is apnea.
No, after we stop.
So it requires after you stop.
Yeah.
Yes.
Okay, so you resume, you give loading, and then you start maintenance. You wait for 3 to 5 days and send them home on caffeine. You bring them back to the hospital after 1 month. You're supposed to have a sleep study. If you do not, because you need to know what type of apnea. Is it central? Then you need to continue caffeine. If it's a peripheral, then or obstructive, then you don't need the caffeine. If it's related to food, you don't need caffeine. So if it's recur, you stopped it. The baby was within the stopping criteria, and you stop it, and it's recur, you need to resume it. And you resume it in the way you resume it first time. So you give loading, and then you give maintenance.
Up to how many months we can keep the baby on?
I continue one baby for 3 months. Now there is no evidence, but most of the time, if you don't have, I continue for 1 month. But if I am sure, sorry, if it's related to feed or it's related to obstructed upper airway, I would stop it even if the baby has apnea. It's very unlikely that you need it after 1 month of discharge, very unlikely. But yes, you can continue if it's a central apnea. You can use apnea even for adult, caffeine for apnea for adult.
Thank you.
After you resume, you have to be sure that the baby is free of apnea spells 3 to 5 days before you decide for discharge.
Correct.
Yeah.
Yeah. And it's safe to send them with caffeine for home.
It's very safe. The margin for safety is very high. We know that they can go up to 80 and there is no problem. We know even if there is a side effect like jitterness or tachycardia or the baby fugue, we know that there is never one reported case that there is heart failure from tachycardia. So even there is side effect, there is no consequences. While we know the benefit is very high. We know it's very safe. We drink it in the tea, okay? We drink it in the coffee. We take it as tablet. So we know there is no problem. So it's very safe. There is no problem of sending babies home. And it was almost my practice. I know here's there a problem, but it is my practice too.
Do we need to keep them on any cardiorespiratory monitoring at home?
No, we said it's useless.
Okay.
Because the study found that use of cardiorespiratory monitor in relation to SIDS are zero. Because why are you sending them on monitor? You think that they may develop ALT or SIDS, right? They die because they stop breathing. They found zero correlation. However, what they found, there's a lot of artifacts and the parent will be very stressed and they keep calling you.
Okay. Okay.
It's of no use.
Thank you.
You're most welcome.
يعطيك العافية دكتور يحيى. شكرا جزيلا. It is really interesting. Can I ask a question if you don't mind?
Yeah, you can go ahead.
Thank you so much. Regarding
don't be hard on me, huh?
no worries.
I am not as smart as you, Ahmed.
No, sorry for that. No way, Dr. Yahya. Please. Regarding the gastroesophageal reflux, it's clear, as you mentioned, that it can be a cause of apnea. And we know that the prokinetics, the proton pump inhibitors, the use of, as you said, even Gaviscon, there's not much evidence that it can help. But what we can do, I mean, we put the baby, elevate his head, the baby's head.
Positioning, yes. No evidence.
Position. Yeah, we can, the feeds, we can space it more, so you can do like a continuous feed even.
This is what about stretching? Spacing mean change it from 2 hours or 1 hour to 2 hours, 2 hours to 3 hours. That's a space.
Yeah.
Or you can stretch it out from bolus to intermittent continuous to continuous. That's also.
Yes.
Remove additives.
Exactly.
Change the formula.
Yeah.
Okay.
This is my question. Now the formula, can we use the AR formula? Anti-reflux.
AR formula is simply a concentrated formula, nothing more than that. So you can add starch or you can add rice to the milk and you're done. Same.
But we are talking about preterm babies whom we are not sure if we add something that it can cause
nothing in the starch. The carbohydrate. In the starch in the rice is just carbohydrate, nothing there. I don't think there is a problem. How they concentrate it? They just put something in it. If you go to YouTube, they can teach you how to do it. But you can use the AR formula. It's just concentrated formula, nothing more than that.
Because that was the aim of Gaviscon. They claim that it is sort of thickener for the formula, for the milk.
I know, Ahmed, you want to find an excuse to use Gaviscon because you love it, but there is no
Excuse me, can I have a comment, please?
You do. Who you are?
I'm Ayman. I'm brother of Dr. Ahmed.
Dr. Ahmed.
Just from gastroenterology feedback. Usually Gaviscon, regarding the acidity, it will not help that much regarding the reflux. But usually the Gaviscon, not like the aluminum hydroxide or others, magnesium hydroxide or others anti-acids. Usually the Gaviscon, it's causing like a layer which is like a barrier that can.
I know the mechanism. I know it works. I know, but I'll tell you why you don't use it. You're talking about premature babies, term or adult?
Usually I'm talking about adult.
Oh,
but
no,
usually
I will tell you why we don't use it. Because it's associated with high risk of infection. All these neutralizer associate with high incidence of infection. Even the H1 receptor antagonist, pantoprazole and these, they are associated with high risk of neck.
Yeah, I know. I know your idea, but no, I'm telling regarding the Gaviscon.
It's not my idea. It's the evidence.
No. Sorry, your evidence. But I know regarding the Gaviscon, it can cause like a barrier layer that prevents the gastric secretions to go up. This is why they are preferring it much better than giving the other antacids, because it has like
I don't give. Ayman, I don't give. I never use it in my life. I never use it. And if it's been
I might bring for you the article that I have seen regarding the I am telling you from gastrointestinal aspect. I'm not telling you regarding my specialty is not like your specialty, but I'm telling you regarding the Gaviscon.
أيمن أنا ترددها مع القراءة عشان أقول لك بالعربي الفصيح يعني. The article you have read, I've read it on it. Okay, and when I give an opinion, I am sure about the positive and negative side of it. First, you do not need to treat reflux, because even if we are doubting that the reflux causes apnea. Okay, that's
last 10 minutes.
Second, even if there is a reflux, apnea due to reflux, it will have no consequences. Third, we know that any gastric acidity neutralizer can increase the incidence of infection and associated with more neck. Okay, so Gaviscon can be used in adult or pediatric. I have no problem with that, but it is definitely should not be used in preterm babies. I know some people are automatic. I know surgeons. I know most of people whose their training not basically neonatology. They are pediatrician and doing neonatology as experience. They love to use it, but I can tell you it's not recommended. It's not recommended by academic pediatric, American Academy of Pediatric. It's not recommended by Canadian Pediatric Society, and there is no evidence of using it. There is, I'm not saying they are not working, but there is no benefit of it. And there is safety, the safety margin is way less. It causes more problem.
Okay,
last 8 minutes. Last 8 minutes. Fellows, حدا عنده أسئلة?
Thank you, Dr. Yahya. And I have a question.
Go ahead.
Like we have preterm babies who were on caffeine, and then after stopping caffeine and you stop oxygen
لا ما في صوت.
You can type, Mona, you can type your question.
They start to have, hello?
Mona, you're interrupted, Mona. Repeat, please.
I was interrupted because I'm on duty. So after stopping caffeine, baby starts to have self-resolving desaturation, but baby's in room air. So do we restart caffeine for these babies? But no apnea.
No, you don't need to resume.
Oh, and what about the long-term effect of these long-term, like recurrent?
We've talked about it, so I don't know if at the beginning we've said if they are not associated with the Brady or other factors, or they are less than 5 seconds, and in cumulative in 24 hours, less than 10 minutes, probably they won't have a, and the desaturation, there might be a reason. So if the patient is not periodic breathing and there is no apnea and continued desaturation, then probably you have another factors, other things that causing the desaturation. So desaturation only without apnea is not a treatment for caffeine. You probably need more respiratory help. They need more oxygen. You need maybe nasal cannula. But you don't give just caffeine just because of it without apnea, if you are sure.
Yeah. Thank you.
You're most welcome. Any more questions?
Thank you.
Thank you, Dr. Yahya.
You're most welcome.
Yeah. Thank you very much.
For the hemoglobin target.
Hemoglobin target, yes.
How much?
Sorry, the question is?
Target hemoglobin, 12 or less for these babies. Target hemoglobin.
Sorry, your name, you are?
Dr. Muhammad.
Muhammad.
Muhammad Mahmoud.
There is no evidence. I personally, as I told you, my practice for baby less than 1 month of postnatal age, I love hemoglobin to be more than 10 if he's on room air, he or she. If she or he on respiratory support, I love it to be more than 12. If he or she above or more than 1 month of age, I love the hemoglobin on room air more than 7. And if she or he on respiratory support, I love it to be more than 10. Now, of course, when it becomes more than 1 month, you have supplements. You have irons, you have other, you have erythropoietin, you can go do more, you have time to do. But it depends on the acuity and depend on other factors. If you have IVH, if you have, other factors, if the patient is sick and so on. So these are my target. Now, what is the evidence? Zero evidence, no evidence.
No evidence, okay, thank you. For other anti-reflux measures, thickeners, positioning, any rule?
Oh yeah, positioning is good. Thickening of meal is good. Changing the meal is good. Stretching it out is good. Spacing it out is good. Infusing it is good. Changing the formula, removing the additives. You can try all these, but I don't know if they work or not. Unless it's iatrogenic. Yeah, when it's iatrogenic, yeah, they can use, because sometimes because apnea, the way you feed the baby. So yeah, you can try them, but what is the evidence? I don't think there is evidence.
Okay. Lastly, for CPAP, the PEEP used, you mentioned 4 to 6. Can I go up or down?
There is no PEEP in CPAP. I don't know who told you PEEP in CPAP.
I mean the pressure level.
PEEP is there is 3 types of PEEP. There is internal PEEP, there is applied PEEP, and there is auto PEEP. And all happen when you're ventilating the patient. And CPAP is not PEEP. CPAP is the pressure applied to the airway above the atmospheric pressure. And the purpose of CPAP in the apnea is to stent upper airway, to make it not soft, because it's very soft, you stent it up. So you can use the level you like, but I usually, when I start apnea, I start with higher level and go down. I don't start with small and go down. And people know me, I use very high CPAP.
Thank you very much, Dr. Yahya.
Thank you very much. I'm done.
We have the last 3 minutes. Next week, our talk will be about transient tachypnea of newborn, respiratory distress syndrome, and BPD, respiratory system.
Yeah.
Will be announced later, but from now, let us
announce later.
That's it for today, I guess.
Thank you very much. Thank you very much. I have to listen to Rola, otherwise you will punish me later.
Thank you very much. Thank you, everybody.
Thank you for attending. Thank you very much. This session will be recorded, and you will have a copy of it.
Lovely.
Okay. Thank you very much. Have a good day.
Thank you.